You have now taken the history from the patient. Next, you will go on and examine the patient. The patient should be fully examined, but there are some specific things to look for. On cardiovascular examination, make sure first that they are hemodynamically stable and assess for a postural drop. Assess for a heart murmur and look for any clinical evidence of heart failure. Don't forget to consider any facial trauma here. Facial trauma implies that the patient did not have enough warning to protect their fall with their arms and can make you more suspicious of cardiac syncope. Look for any evidence that this could be a pulmonary embolism. On abdominal examination, ensure there is no pulsatile abdominal mass and look for evidence of gastrointestinal bleeding. As we have said, it is not common for a stroke or TIA to present with a loss of consciousness. However, any ongoing neurological deficit could suggest a Todd's paresis and would make a seizure more likely than syncope. Next, you need to think about investigations. There are some investigations everyone presenting with syncope should have. There are also some investigations that may be required if the patient has certain features thus far on your assessment. If you are not sure, don't forget the syncope pathway is there to help you. Everyone presenting with syncope should have blood tests to check their hemoglobin, electrolytes, and blood glucose. Don't forget to do a lying and standing blood pressure if you haven't already. All patients presenting with syncope will need an ECG. We will now go through some specific examples. This ECG shows complete heart block, as there is no association between the P waves and the QRS complexes. This patient needs an urgent pacemaker, so it is an important diagnosis and easy to make if you look carefully at the ECG. Here you can see widespread ischemic changes. There is ST depression seen in leads 1, 2, and V5 and V6. There is also some subtle ST elevation in V1 and V2 and AVR, with small Q waves in V1 and V2. This is concerning for a proximal left anterior descending artery occlusion and is likely to need urgent PCI. The corrected QT interval in men should be less than 440 milliseconds and less than 460 milliseconds in women. There are lots of causes of long QT intervals. Some of the causes are listed here and include drugs, as well as electrolyte derangement, and of course inherited long QT syndromes. This is an ECG of a young patient with some hypertrophic changes. You can see increased precordial voltages and non-specific ST segment and T wave abnormalities. This is concerning for hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the most common inherited cardiac disorder, affecting around 1 in 500 people, and is the #1 cause of sudden cardiac death in young athletes. Also keep in mind that asymmetrical septal hypertrophy produces deep, narrow, dagger-like Q waves in the lateral and inferior leads. You can see them here in lead 1, AVL, and V5 and V6. Brugada syndrome is an ECG abnormality with a high incidence of sudden cardiac death in patients with structurally normal hearts. The definitive treatment is an ICD. Look for coved ST elevation in V1 to V3, followed by a negative T wave. So that covers what you were looking at on the ECG. There are also some other investigations to consider based on your assessment thus far. For example, a troponin, if your assessment so far has led to you considering acute coronary syndrome, a D-dimer if you're considering a PE, thyroid function tests if there are features suggestive of a cardiac arrhythmia or if anything else in the history or examination suggests a thyroid disorder. Consider a pregnancy test in young women. You may wish to do a CT head if you are considering a subarachnoid hemorrhage or if you are concerned about a head injury from the fall, especially if there is facial trauma or the patient is anticoagulated. Don't forget, the syncope pathway is there to help. Ask yourself, is syncope still your #1 primary diagnosis? If you think a seizure is more likely, A referral to neurology is more appropriate and you should no longer follow the syncope pathway. If you are satisfied that syncope is your primary differential diagnosis, then watch our third and final video to find out what you should do next.